Okay, so today we are going to discuss about angina. Um, as we all know, there's two different types of angina pectoris, which is one is stable and one is unstable. So today we'll be discussing more about stable angina, and I'll be discussing the unstable angina in PCI in the another section under the another section like acute coronary syndrome. So today we'll be focusing on stable angina. So as we all know, how do we define angina? So this is the three main thing that I usually like put when I defined angina. So this is three things that you should remember. So the first thing is discomfort. So whenever the patient comes to an emergency with angina, they usually express the discomfort that they felt. So they classically described as a squeezing, which felt in the chest, right, or the adjacent area. So what is the reason behind it? It's the myocardial ischemia. So what is myocardial ischemia? It actually um, developed due to the inadequate blood supply, right, or the oxygen to the heart muscles. And what is the most common underlying cause for myocardial ischemia? That is the CAD, the coronary artery diseases. So CAD is the most common. There are other risk factors too, which we'll be discussing further, like in the later slides. But CAD is one of the most common underlying cause of myocardial ischemia. So it is basically the buildup of cholesterol plaques in the wall of the heart muscle. So again, squeezing and discomfort. Discomfort classically described as squeezing, right? And it is due to myocardial ischemia. And what is the most common cause? CAD. Now, let's have a look at how do we differentiate. So most of the time we know like the angina can be differentially diagnosed as different types of conditions, right? So there are a lot of differential diagnoses for chest pain, not angina, sorry, like chest pain. So how do we diagnose the if it is typical or atypical or non-anginal pain? So what basically the physician does in the emergency is like they ask three questions to the patient. So the first question is the discomfort is substernal? So if the discomfort is substernal, yes. If the patient say yes, yeah, okay. Now the second question is, are the symptoms precipitated by exertion? So the patient says yes, okay. Now the physician asks, are the symptoms relieved within 10 minutes of rest? If the yes, then that means it's a typical angina. What if the patient responds yes to two questions? So if the patient responds yes to any of the two questions among these three questions, that means that angina is a typical angina. And if the patient say or responds yes to one question or no questions, that means it's non-anginal. So, like I said, like it can be due to underlying, the chest pain can be due to some kind of like, sometimes it can be differentially diagnosed as dyspepsia or GERD, right? Or it can be kind of any kind of like chest wall syndrome. It can be a lot of differential diagnoses are there out there. So for the chest pain. So again, this is the first thing that the physician does. Like when the patient comes to an emergency with pain, they have to make sure the chest pain is related to angina, or if it is atypical or non-angina. Again, you have to remember these three questions. Wherever you go in emergency, the physician will look up for these three questions. So substernal, if the pain is substernal, the discomfort is like substernal, or if it is precipitated by exertion. So it can be other factors too, like it can be exposure of cold, right? Exposure to cold or emotional stress also can precipitate angina. So that also can be considered. Now, if it is relieved by rest, that is another thing. So if it is not relieved by rest and patient have a pain and it is due, patient is precipitated by exertion, that means it's atypical. But if it is relieved by rest, that means it's a typical angina. Now, what are the factors that provoke angina? So we know that the two main things that worsen the angina is increase in the oxygen demand and decrease in the oxygen supply, right? So what are the factors that can increase the oxygen demand? So a lot of factors are there. I didn't put much factors up here. So in hyper or hypothermic condition, the oxygen demand can be increased. In hyperthyroidism, in heart failure, the oxygen demands can be increased, right? So, and also, what are the other situation like in kind of what is the reason behind hypothyroidism? Because increase in the thyroxine makes more sensitive to the circulating catecholamines. So, right. So that's the main reason why it increases the oxygen demand. And heart failure, if the patient have tachycardia or sympathetic toxicity, in these are the other reasons where the oxygen demand can be increased. Now, let's have a look at what are the factors that can decrease what are the situations, conditions which decreases the oxygen supply. So when I say decrease the oxygen supply, just imagine like it should be something related to a decrease in the blood flow, right? So first of all, like it can be hematological conditions, right? So anemic, if the patient is anemic, or sickle cell, or hypoxemia, or it can be pulmonary conditions, right? So a decrease in the oxygen supply. So it can be asthma or COPD, or if the patient have a pneumonia, it can be pulmonary fibrosis, and some other cardiac conditions like any kind of coronary spasm or obstruction, or it can be aortic stenosis too. So these are the factors that provoke or worsen angina. Now, there are certain drugs that also can provoke or worsen angina, like CNS stimulants, or the triptans, which used for antidepressants, like triptans, and sodium nitroprusside. So we discussed sodium nitroprusside in where the hypertension emergency, right? So this one of the thing that can worsen the chest pain. Now, um, medications like dobutamine, which we used in the heart failure, acute decompensated, like cardiogenic shock, dobutamine, and so these are again, the first thing when a patient comes to clinic or emergency, first thing is to identify the risk factors, and first of all, the physician will make sure it's a typical angina. Now they will identify the risk factors, then they screen the factors that provoke the angina. Then they will start the treatment. Now you might be wondering, if the patient have an angina, should we wait for all these things to do? No, we right away we give the nitrate, sublingual nitrate, which we'll be discussing in further. It's what I'm trying to say is when the patient comes to emergency, so we do the nitrate treatment right at the home, like when the patient develops the chest pain, which we'll be discussing. But these are the assessment that physician does, like when the patient comes to a clinic with the complaints of chest pain. Okay. Now, what are the other risk factors? So just again, we can classify it as a modifiable and non-modifiable. So we have the modifiable core morbidities like diabetes, hypertension, if the patient have hyperlipidemia, CKD, depression, obesity, all those things. Lifestyle modification. So we can help the patient or educate the patient, or we can intervene the patients to smoking cessation programs, and poor diet, all these can be a risk factors for angina. Now, what are the some non-modifiable risk factors? Age, gender. So, gender, typically men have more risk to angina at younger, and females at older age. Okay, so again, men have more risk to angina at younger age, and females at older age. Now, family history. Why did I highlight in red? Because there is one thing that you have to remember here. When the when we take the family history of the patient, it's not just do you have a history in family history of if anybody have in like in your family have angina. That's not how it works. There is a certain, like in guideline, it says that if the patient, if there is a history of premature cardiac death, that means death in first degree male relative at younger age below 55. So if your relative, first degree male relative, it has to be a first degree male relative, have a premature cardiac death at the age below 55. Okay, or death in first degree female relative at age of below 65. So this is the family. If it is above 60, we don't consider. So if it is a first degree male relative, it has to be a premature cardiac death has to be occur below 55. If it is above 60, we don't take it as a family history. So, and if it is in first degree female relative, the age has to be below 65. Okay, so that is really important to notice. Now, other non-modifiable risk factors we can say, like African Americans have high risk of having angina. So those are the risk factors and factors that provoke the angina. Now, why it is important to identify these alternative causes of angina? So we discussed that CAD is one of the main cause of angina, right? Now, there are other conditions that can worsen the angina too, like if the patient have aortic stenosis, cardiac myopathy, anemia, this can worsen the angina. Why it is important to identify these alternative causes? So again, the first most common underlying cause for myocardial ischemia is coronary artery disease. Now we have another alternative causes of angina too. And why it is important to identify? Because as we all know, it is really important to ensure that uh, inappropriate treatments are not given for the patient. So, for example, we all know that nitrates is one of the most commonly like first line agent for acute angina, nitroglycerin, right? So, if the patient if the angina is due to hypertrophic cardiomyopathy, it can be harmed. If given the patient on long acting, we can use it for the acute treatment, but it's not a problem. But if we try after that, we start the long term therapy for the patient. So if we use the long acting nitrate therapy on those category of patients, it can be harmful for the patient. So that is the reason it is important to identify these alternative cause of angina. Okay. So again, initial assessment includes we take the history, we identify the risk factors, we screen for the factors that provoke the angina, that which we already discussed. Then we do the physical examination. Sorry. So physical examinations usually involves we take the heart rate, and we can check the blood pressure. I mean, the physician checks the blood pressure. Then we will then there is something called they'll check for the cholesterol. So physically they can do the examination for the cholesterol. So what is it called, like they call it as arterial brutes, which I will type right here down here. It's actually like a sound, abnormal sound generated by the if there is a if there is a plaque or anything in the artery, it produces an abnormal sound. So the physician can hear it using the stethoscope. So we call it as arterial brute. Okay. So these are the kind of physical examination they do. Then we'll go for the lab assessment. So we take all the lab assessments because CBC, creatinine, electrolytes, glucose, cholesterol, pretty much everything. Now we do the non-invasive cardiovascular testing. So we take the resting ECG. Again, we take the resting ECG because sometimes it can be precipitated due to exertion. Sometimes so we have to know that how much, what is the level of exertion the patients can take. So we do the resting ECG. We do the echocardiogram. So echocardiogram is not doing for the diagnosis of angina. Instead, rather it's done to identify any kind of underlying valvular diseases, heart diseases, if the patient have any systolic dysfunction or anything, cardiomyopathy, like that. So then we do the stress testing. How do we do the stress testing? Is like either we ask the patient to exercise, or it can be the stress can be induced by means of pharmacological agents, so such as adenosine or dobutamine. So the patients get injected with the certain amount of strength of dobutamine, which produces a stress to the chest, like heart, and they will do the stress testing. Okay. So again, these are the steps of initial assessment. Now, now let's have a look at the management of stable angina. So the two important goals of management or the therapy is to improve the quality of life by decreasing or preventing the angina and improving the exercise tolerance of patient. And also we have to reduce the mortality or minimize the mortality by minimizing the risk of cardiovascular death, we could say. Okay, so how do we do that? We have to treat the modifiable factors which promote the development and progression of CAD. So we already discussed what are the modifiable factors, so we have to focus that. And we also start on medications which can reduce the mortality, which we'll be discussing shortly. So how do we improve the quality of life? So first, the patient having a chest pain, we have to start right away acute treatment, right? We cannot wait until chest pain, like we can't wait until to get the patient to the emergency. So we right away give the nitroglycerin sublingual tablet or spray. So again, sublingual tablets and spray is only used for the acute treatment. Okay, so how do we do that? We give the first dose of it, then within 5 minutes, if there is no improvement in the patient condition, we call the emergency, call the ambulance right away. So again, um, patient develops the chest pain. It's really important to notice, like patient develops the chest pain, give the nitrolingual tablets or spray. So the first dose is given and there is no improvement, we call the ambulance right away. So there is a period of time that we have to wait for the ambulance to arrive, right? So how many doses we can give total? So we can give 3 doses, and it has to be an interval of every 5 minutes. So maximum 3 doses we can give. So we give the first dose right away, and we call the ambulance. We are waiting for the ambulance. Then patients, there is no improvement in the condition. We give the next dose in 5 minutes. We give next dose, another dose in 5 minutes. That's it. Then we cannot give more than that. Then the ambulance comes, we take the patients to the emergency, then they will figure out they will do all the assessment, and like then they will start the patient on chronic treatment. So again, beta blockers is the first choice, especially when it comes to heart failure with angina. So we discussed in heart failure, beta blocker is one of the medication that used in heart failure. Again, we cannot use it in acute decompensated heart failure. So I don't want to confuse by saying that. So I mentioned in the second, in the beginning, it is really important to identify the alternative causes for angina. So here one of the example is heart failure. So if the patient have heart failure, we cannot start the patient on long acting nitrate. We have to give the patient with beta blockers. So that is the first choice for that. Even though if it is just the angina, beta blockers is always the first choice for the chronic treatment. Now we can also give long acting calcium channel blockers. It doesn't matter if it is dihydropyridines or non-dihydropyridines. We can give both category of calcium channel blockers. So we can start that on with the patient. If the patient, there is no improvement in the condition with these two classes of medication, then sometimes the physician adds long acting nitrates too. So if there is an inadequate relief with these two medication, then we add the long acting nitrate too. So it's pretty much clear. Again, acute treatment, we give the nitroglycerin sublingual or spray every 5 minutes. So we can give like total of 3 doses. So we give the first dose, there is no improvement in 5 minutes. We call the ambulance, we give the next dose, then again wait for 5 minutes, then again give the third dose. Then we start the patient on the chronic treatment, beta blockers. The chronic treatment includes the beta blockers, long-acting calcium channel blockers, and long-acting nitrates. So chronic treatment is basically we use it for the prevention of angina too. So um, if the patient if the when they do the assessment, sometimes if it is really clear, like when the patient do the exercise of if the patient exposure to cold is the reason that produces the angina, then we usually suggest the patient to take use the patches. So long acting nitrates includes patches, right? So we have the long acting tablets and the patches so available. So sometimes we recommend the patients to take a tablet before the going out, or before they get the exposure to cold or heat, or before they start doing exercise. If before they going to gym, if exercise is the situation where that produces the angina, then we ask the patients to use the tablet before going to gym. So see, it's used for prevention too. Now we have to reduce the mortality. So how do we minimize the risk of cardiovascular death? So we start this three category of medication. So unless it's contraindicated. So if the patients have any other situation where they cannot use the antiplatelet, if there's a high risk patient, where the high risk patient means high risk for bleeding, okay, we cannot start the patient on antiplatelet, then we cannot. But if it is, unless it's contraindicated, we have to, it is very important to start the patient on antiplatelets, statins, and ACE inhibitors. So pretty much in all patients, we start the antiplatelet, like aspirin is the first choice of drug. Um, so aspirin like 80 milligram to 160 milligram we can use in this situation. So aspirin is the first choice of antiplatelet. We start for a long term, especially when it comes to coronary prevention of cardiovascular conditions. So it has a really good studies have shown that it reduces the mortality and especially the risk of cardiovascular death. So statins is also so antiplatelet. We use the aspirin. I said. What about the P2 like the clopidogrel? Can we use that? So it seems like the other antiplatelets like the medications we cannot use it. The anticoagulants. Why? Because the studies have shown that there is no significant improvement by using the uh, clopidogrel, the anticoagulant. So we usually go with the antiplatelets. So we usually go with the aspirin most of the time. So, but if the patient cannot tolerate the aspirin, then the another second line option is clopidogrel, unless if the patient cannot tolerate. So if the patient can tolerate the aspirin, we always go with the aspirin. Okay. Now, second agents are the statins. So statins we typically use pretty much every statins. There is no difference. So we'll be discussing much more about the statins and cholesterol, hyperlipidemia. So as we all know, statins decreases the cholesterol level. So it's not just decrease the cholesterol level, but it includes improving the endothelial function. That is the main reason that we use it for the angina, for the long-term treatment to reduce the mortality. So again, it improves the endothelial function too. And so in most of the patients, we start the statins unless there is a interaction or most of the patients with established vascular diseases, we start the patient on statins. So even especially with a patient are high risk of cardiovascular events. Okay. Now, the another category of medication is ACE inhibitors. So ACE inhibitors, we already discussed in hypertension, what is the mechanism of action and stuff. So ACE inhibitors, we try to start in many patients as possible. If the patient cannot tolerate the ACE inhibitors, especially if the patient develops the cough or angioedema, we can switch to ARBs2 here. We already mentioned that in the first class. So again, cough and angioedema is the only situations we can switch the ACE to ARBs. Okay. Now, what are the other situations? So we have to identify, address any modifiable risk factors. So that is also the part of reducing the mortality. So we have to address any modifiable risk factors. And if it is possible, we have to stop the HRT and NSAIDs. So NSAIDs is one of the class of medication that can cause increase the cardiovascular death, right? So we already discussed that. And hormone replacement therapy, estrogens, a lot of things. So why I'm saying the HRT and NSAID is most one of like very important class of medication that you should know. Why I'm saying HRT is because postmenopausal women usually like go with them, because we said that in age, women's more chances to get angina in when they get like elder, like at elder age, right? So above 50 or 55, the high chances of angina is more in women. So most of the reason behind is like the use of HRT. So if it is possible, we have to stop HRT. If it is deemed necessary to treat the menopausal symptoms, what we would suggest is like to keep the duration of therapy to a minimum. So it not like it doesn't result in developing the angina. So again, the best option is to stop the HRT. Now, same with the NSAIDs. So if it is possible, if it is deemed to necessary, we have to administer the lowest dose with shortest possible duration. So that's what we can do. Okay. Now, let's talk about nitrates. We pretty much discussed all the classes of medication before, except the nitrates and the statins. Statins we'll be discussing tomorrow. We'll be discussing the antiplatelets, so I'm not touching that today. Statins we'll be discussing in cholesterol, like hyperlipidemia. Now, let's discuss a little bit about nitrates. So, as you all know, what is the mechanism of action of nitrates, guys? How does the nitrates works? Anybody? Vasodilation, right? So it actually is a prodrug, we all know. So how does it act? It's liberating nitric oxide, right? So we all know that nitric oxide is a endothelium derived what? Relaxing factor, right? So it results in vasodilation. Now, in coronary artery, it results in vasodilation and it increases the cardiac oxygen delivery. But when it comes to vein, it decreases the preload and it decreases the oxygen consumption. Now, how about the cardiac output? Does it have any effect with cardiac output? No, actually, cardiac output remains the unchanged. Okay, so it also have the smooth muscle relaxing effect as well. So again, like I said, it liberates the nitric oxide and it results in vasodilation. In coronary arteries, it increases the cardiac oxygen delivery, and in veins, it decreases the oxygen consumption. Okay. Now, the important things here, we already discussed pretty much all the indications. So in heart failure, we use it as like in NIHA class 4. If the patient like comes reassess in 3 months and still the patient have no improvement, we add the hydrolysin and nitrates, which we already discussed. Here in other indications, when it comes to angina, the important thing we have to remember is that treatment of acute angina, we can only give sublingual. So it can be sublingual tablets or spray. We cannot give long-acting agents. So acute angina, we have to give sublingual tablets or spray. In prevention of angina, we can go with long-acting oral or patches, transdermal patches. Okay. There are other situation indications also, which we already know that in heart failure, right? And in hypertension emergency, we use the nitrates, IV nitroglycerin, right? So, which we all know already. So, what are the few adverse drug reactions? So, most common adverse drug reactions seen in patient is the headache. So headache is usually due to the vasodilation action of the nitrates. So especially it's been seen with long-acting agents, headache. Okay. So how can we manage the headache? Sometimes we can ask the patients to take acetaminophen. Usually it goes away in few days. So we don't have to worry much about the headache. But most frequent is headache. Now patient can develop hypotension, dizziness, patients can have reflex tachycardia. So whatever the drugs that can cause vasodilations will have the side effect of reflex tachycardia. We discussed in calcium channel blockers where the dihydropyridines, which acts similar to nitrates, right, has the adverse effect what? Reflex tachycardia. But in non-dihydropyridines, the adverse effect was bradycardia because it acts similar to beta blockers. Now, there are also some reported cases of hemoglobinemia. So that is one thing we have to remember. So it is characterized by shortness of breath, cyanosis, fatigue, dizziness, loss of consciousness. So we'll be discussing the drug interactions too here. So alcohol, antihypertension, phosphodiesterase 5 inhibitors like sildenafil and tadalafil. So these are the medications that contraindicated. Especially you have to remember the phosphodiesterase 5 inhibitors because it's really important. We probably in our pharmacy, probably we come across with a lot of people uses this medication. So one of the most common auxiliary label we use on those medication, do not take with nitrates. So we usually recommend do not take it with nitrates, but there are situations where the patients cannot avoid. We usually suggest, the studies have shown that at least the sildenafil can be separated like in 48 hours, or if it is tadalafil, it has to be separated with 48 hours. Okay, but it is again, like I said, it's more important. It is better to avoid taking um, phosphodiesterase 5 inhibitors along with the nitrates. Okay, why alcohol and antihypertension? Because antihypertensive, because it can lead to more dizziness and hypotension in patient. Okay, now um, there is something like something called heparin resistance. So when we give the IV nitroglycerins, and if the patient is on heparin, it can cause heparin resistance. So that is another thing that you have to remember. Now, the key points to remember here is when we use the long-acting agent, it is important to make sure that patient is having or getting free nitrate-free period for 10 to 12 hours. Why? Because it can develop tolerance. So it is really, really important nitrate-free period of 10 to 12 hours. Okay. And so we always advise the patient to sit while taking the sublingual nitrates because to reduce the risk of syncope. And we can, again, like I said, we have to separate the sildenafil at least 24 hours. If the patient cannot avoid that medication, then we suggest to at least separate it by 24 hours, or tadalafil like 48 hours with the sublingual nitrogen, nitrate, nitroglycerin patches or patches. Okay, if it is patches, we have to separate it like at least 5 days. So after the discontinuation of the patch. If it is sublingual, we have to separate it like with 24 hours and 48 hours respectively for the sildenafil and tadalafil. If it is patch, we have to separate it like 5 days after the discontinuation of transdermal nitroglycerin. Now, we already discussed this. Acetaminophen can be used to treat the headache. Again, it can go away like within few days. So even though it is the most frequent, it can go away like in few days. So now let's have a quick look at the storage of the medication. Why I'm mentioning, usually don't mention the storage of medications usually. So here why I'm mentioning is because it's really important. As a pharmacist, you should educate the patient how to store the medication properly. So because it can lose its potency here, especially with the nitroglycerins, we all know that it is sensitive to the light. So we have to dispense the nitroglycerins. So usually always dispense the nitroglycerin in original container. We do not break the container. We should not break the container. So we always try to, it's not try to, we always dispense the nitroglycerin in original container. So it has to be stored in amber color bottle. So it comes in amber color. The manufacturer packs the medication in amber color, so we don't have to worry. So it should not contain more than 100 tablets. That is the one thing manufacturing monograph, if you look, that it should not contain more than 100 tabs. And we should renew the stock every 6 months. Why we should renew the stock every 6 months? Because it can lose its potency after 6 months. So that is the one reason that we have to make sure we renew the stock. Stock means not only the pharmacy stock, even the patient. If the patient have a one bottle of nitroglycerin and the patient use it for like a year, no, every 6 months the patient has to renew it. So, and it can also cause false test result for serum cholesterol. So if the patient is having a cholesterol test appointment, lipid panel test, and the patient take the nitrates in the morning, then it can result in the false test result. So that is the another thing you have to remember. Now, when it comes to spray, one thing is I have seen is a lot of patients inhale the spray using the mouth. So they usually like do it same as they use the inhalers, the salbutamol inhaler. They inhale it. So nitroglycerin spray is not meant to inhale. Again, it's a sublingual, right? Sublingual spray, sublingual nitroglycerin. So it's not for inhalation, guys. So again, when we educate the patient how to use the device, so pharmacist is another role of pharmacist to educate the patient how to use the inhalers and how to use the medical devices, right? So spray is not meant to be inhalation. So we have to spray it, then close the mouth immediate after use. That's all they have to do. So they don't have to inhale it. So it uh, unlike the tablets, spray actually maintains its potency till the expiry. So whatever the expiry is on written on the bottle by the manufacturer, it maintains its potency until that date. So we don't have to worry about the potency like in tablets. We don't have to renew the stock every 6 months. Uh, do not shake. Again, certain medication inhalers, not every inhalers, like certain things we have to shake before use. Here the spray we don't have to shake before use, so do not shake. And we have to make sure that we educate the patient how to do the prime. So always every device, so all the devices, inhalers and stuff, we have to do the prime in the beginning, right? So there is a prime for the nitroglycerin spray too, and the patient has to do the prime at the first time. And also, if the patient is not using it for the 2 weeks, it's not been like the patient used it for the first time, then a patient primed and used it for the first time, and patient is getting the next chest pain like after 4 weeks or after 3 weeks. Then when they use it, they have to make sure they have to reprime it. Okay, so that is the one thing. Very really important to notice, because most of the medication that we do the prime, we have to do only once, but here in this case we have to reprime it if it is not used for 2 weeks. Okay, and it can vary per products. Like per products means depends upon the brand. So we have to go with the. There is something called reprime, but it can vary. It can be like 3 weeks, 2 weeks, or 1 week. So you have to go with the product manufacturing product monograph. Okay. Now, when it comes to patches, use a different site every day. So we don't have to use. We don't want to use the same area every time. So we always ask the patients to use a different side every day. We have to make sure that the area is clean before using it. If the application of patches make the skin dry, we can ask the patients to use they can use the soothing lotion. So we usually don't want to use it like, we try to avoid the extremities like below the knees or elbow, or especially the skin fold. We don't want to use the patch in skin fold. We avoid the skin fold. If the patient have a scar tissue or a burned or irritated area, we don't use it. Okay. Now, sometimes the using of patch can make feeling like skin may feel like warm. Sometimes it can redness. It can lead to redness of the skin. So these the symptoms will disappear. So if the patient have any concerns regarding, oh, my skin is getting warm and turns to redness, you don't have to. You have to educate them that it will disappear eventually. So there is nothing much to worry about those things. Now, can the patient shower with the patch? What do you think? Can the patient shower with? So your patient is asking you a question like, patient have a concern. I'm using the patch. Can I shower? I have to take a shower. Can I shower using the patch? Yes or no? So usually, uh, patient can shower while the patch is on. So it's not a problem. So patch is not gonna shower is not gonna affect the release of medication. So again, remember this point: patient can shower using the patch. What if it detaches? So patient applied one patch. So used one patch. So it has certain strength of medication, right? So and suddenly it got detached after like 5 minutes. So it's supposed to release the medication for 24 hours, but it got detached after like an hour or like 2 hours. What we can do in this case? Can we apply a new patch, or should we try to reapply it? So most of the time we ask the patients to reapply it. So, and if the reapplication of the patch, the same patch is not working, then if it falls again, then try to apply a new patch, but only use the new patch for the rest of the duration. We don't want to use the new patch for the full time, like for 24 hours. So whatever the rest of the duration of dose duration, we have to use the new patch. So that is the another thing you have to remember. And also nitroglycerin ointment is also available. It has available in 2% strength. So usually it is applied as a BID dosing, like in the morning, then 6 hours later. So when I said nitrate free period, here one thing I have to mention is like usually the nitrate free period is really good at night. Why? Because the angina symptoms is very less like prevalent at night time. So we usually recommend to go with nitrate free period at night. So we usually recommend the patient to use in the morning, patches in the morning, and uh, go without patch at night. Okay. Now let's have a look at few non-drug measures. So what are the non-drug measures that we can suggest to patients? So we can do the aggressive lifestyle interventions, like we already know that what are the factors that can cause. So like we can counsel the patients to take exercise, right? So make sure that the patient undergo the stress testing before we recommend the exercise for the patient. Okay, so what are the aerobic exercise, like regular, like walking, jogging, cycling, swimming? These things is not going to be a problem, so we can recommend those. And healthy diet, especially low sodium, is really important. Now, quit smoking, so we can intervene smoking cessation programs in patient, right? Alcohol consumption in moderation, and if it is the high risk patient, and then we have to advise the patients to, instead of suggesting them to do exercise, we can go with medically supervised programs like cardiac rehabilitation. So that is another option for high risk patient. What about the revascularization? So especially in patients with refractory angina, so nothing is helping. The patient is on medication, still the patient is getting the chest pain. Nothing can control the angina. That is refractory. So those in refractory patients, we do the revascularization. So what are the two methods of doing the revascularization is like PCI, which is called as percutaneous coronary intervention, and it also known as coronary angioplasty. You might have heard about it. Then we have the CAPT, which is the coronary artery bypass graft surgery, right? So these are the two methods we can do the revascularization in refractory patients. Okay. So these are the non-pharmacological thing. Now, few therapeutic tips for here. So this is the last slide, guys. So like I said, angina is pretty much very easy to learn. So therapeutic tips is here. We have to schedule. We already discussed here. Like it's just repetition of few steps that you have to remember. So again, like I said, we schedule the nitrate free period time for a long time. When minimal symptoms, like for a long time, like at least 10 to 12 hours. So when minimal symptoms, so usually at night time, patients will have the minimal symptoms. So we go with the night time. Although beta blockers are best titrated to resting heart rate. So usually here, whenever we give the beta blockers, we titrate the beta blockers to resting heart rate. Here, I think I made a mistake here. 1 second. So we usually do it with the, okay, let's change this. Let me change this, okay? So it's not resting heart rate. So in books, we can see that we usually titrate the beta blockers to heart rate during exertion, okay? But clinically, when doing the treatment of angina, they usually do it, titrate the dose to resting heart rate. So that's what they do. Why? Because resting heart rate, because angina sometimes, again, like we said, we have to, most of the situation why the angina is precipitated during the exertion, right? So we have to make sure that the medication helps the patient with the resting heart rate, not just the exertion. So that's what we do all most of the time. So we in angina, we clinically we titrate the dose to resting heart rate. So and we cannot withdraw the beta blocker separately. Why? Because it can cause reflex tachycardia, and it can, like, rebound tachycardia, not reflex, sorry, rebound tachycardia. It can worsen the symptoms, right? So if the patient is on antihypertensive agents, and the patient is like taking a high dose of beta blockers, and now we have to stop medication beta blockers right away, like we have to be very careful. We should not. We have to taper the dose like in 2 to 4 weeks, that which we already discussed in hypertension. If beta blockers is desired in resting bradycardia, so here remember it's not resting heart rate. If we want the patient to use, so if the patient have, in resting, even in the rest situation, in resting, if the patient have bradycardia, so we know that beta blockers, one of the adverse effect of beta blockers is bradycardia, right? Severe bradycardia. So if the patient at rest itself have bradycardia, The desired beta blockers is the beta blockers with intrinsic sympathomimetic activity, which we discussed. What are the two? Give me a few examples of beta blockers with intrinsic sympathomimetic, which we discussed in the first class. Give me a few examples, guys. Like we discussed in the first class. What are the beta blockers with ISM?
Acebutolol,
Yes.
pindolol.
Pindolol, yeah, right? Yeah. So most commonly used is acebutolol or pindolol. Pindolol has the most ISM activity. Now, again, it's really important. So we discussed in the first class that if the patient, if there is a concern of bradycardia, if there is a concern of lipidemia, if the concern of peripheral artery diseases, or if there is a concern of blood glucose, diabetes, we can go with beta blockers with ISM because ISM have partial effect on the heart rate, or we can call it as a partial agonist or antagonist. So, okay. Now, what about the Prince metal angina? So, we probably might have heard about Prince metal angina. So, or we can call it as a vasospastic angina. So, on those type of angina, we should not use the beta blockers because why beta blockers can decrease the contractility, right? It has the effect on contraction, so it's the negative inotropic. So we do not want to use the beta blockers on those type of angina. We prefer the calcium channel blockers or nitrates. So now you might be asking me, ma'am, the calcium channel blockers, even the non-dihydropyridines act similar way as beta blockers. How can we use the calcium channel blockers? Why? Because calcium channel blockers act similar to beta blockers, like especially the non-dihydropyridines, but it affects on heart rate. So it has the same action on heart rate. So it decreases the heart rate. Beta blockers decreases the heart rate. But when it comes to contractility, beta blockers is more potent when it comes to like contractility. So it has a negative inotropic effect. But calcium channel blockers, mainly heart rate, but have less effect on the contractility. That is the reason that we can use the calcium channel blockers and nitrates in prismetal angina. Okay. When it comes to refractory angina, so we discussed what is refractory angina. Refractory angina is like patients have a chronic angina despite of any treatment. There is no development in the condition of the patient. That is called refractory angina. So in that case, ivabradine, which we already discussed, is a new class of medication where it actually decreases the heart rate. But what are the two situation, like what are the two what are the who are the candidates for ivabradine? We have to make sure that the sinus rhythm is normal, the heart rate is between 70 and 77. Why? Because it has a potent effect on decreasing the heart rate, guys. So we have to make sure that patient have a heart rate is like very way up to decrease, or the resting heart rate is normal, because we don't want the patients to go bradycardia. So that's the reason. Now, another situation is we have to make sure the systolic blood pressure is more than 100 before starting the ivabradine. So again, we try to avoid when it comes to the combination. We discussed that we can use both classes of calcium channel blockers in long-term treatment. But if we have to combine the treatments, for example, we start the beta blockers for long-term and the patient has no improvement, sometimes the physician go with the ideal combination of agents instead of switching into CCBs. The physician will try to for example, if the patient have heart failure, like we discussed, the patient cannot take the long-acting nitrates, right? So in that case, the physician may try to combine the agents like calcium channel blockers and beta blockers. So in those situations, when there is a combination has to happen, try to avoid the non-dihydropyridines calcium channel blockers with beta blockers. Try to use the dihydropyridines one. So dihydropyridines literally gives the action of nitrates, right? Vasodilation, and beta blockers does its job. So try to combine the DHP with the beta blockers, not non-DHP, okay? Because it can worsen the bradycardia. So and it can decrease the heart rate very. It can go down, so the heart rate can go down, and it can cause the bradycardia. So we always try to avoid this combination. Can we use this combination? And there can be some situation where you will come across where the physician use this combination and they monitor the patient bradycardia, the heart rate. But most of the time you try to avoid it. Okay, like I said, all the adverse drug reactions and are not contraindication. So you have to be very careful. So you come across with a lot of things where the physician prescribes and we'll be wondering why the physician is doing this. Isn't it contraindicated? So, but that's not how things works. So whatever written in the books, you will see significant difference when you come into practice. You will see, it's a lot of clinical judgment is based. Like I said, clinical judgment is one of the most important thing when it comes to practice. You have to, that what we do the monitoring and stuff. So there, but just remember when I say that doesn't mean we have to. Can we use the ACE inhibitors like in pregnancy, third and second and third trimester? Yes, but most of the time they will try to avoid it. So there are situations where there is absolute contraindications like lithium toxicity and stuff. We cannot. We have to absolutely. Lithium is absolutely contraindicated. So those are the situations that absolute contraindication we just have to follow. But there are situations that we can even there's the interaction, we can start the medication and we can use that medication on the patient. Okay. So if the ACE is not tolerated, we can switch to ARBs, which we already discussed. And the two situations we can switch is like cough and angioedema. So like I said, if there is a question or if the physician asks, can we switch the ACE? The patient is having acute renal failure or aortic stenosis, like bilateral stenosis, renal stenosis, or patient have a solitary kidney and patients having the creatinine clearance is like going up, and physician asking your suggestion, can we switch the ACE to ARB? The answer is what? No, we cannot. Because why? The ARBs and ACE has the same mechanism of action, and it actually both of the class of medication can affect the kidney function, right? So we cannot switch ACE to ARB in that condition, but only two conditions where we can switch the ACE to ARB is cough or angioedema. Okay, do not forget that. All right, now I think that's all about the angina. So do you guys have any questions from the angina section? Anybody have any questions? Okay, so it's pretty much easy, the angina, the treatment. All you have to remember is like the acute treatment, chronic treatment, and how to reduce the mortality of the patient. So it's not only to improve the quality of life, we have to reduce the mortality when it comes to this angina. So we do the acute treatment with sublingual nitrates. We do the chronic with the long-acting ones, beta blockers and calcium channel blockers. Then we try to address the modifiable risk factors, right? And we try to, if possible, we try to avoid the risk factors such as NSAIDs and HRT. And we also start the patient in three classes medication, which is seems to be reduce the cardiovascular death. Which are what are the classes of medication? Antiplatelets, statins, and ACE inhibitors. So it's pretty much easy. There is nothing much to. It's not much complicated. Like hypertension. So I hope it's clear so far. Okay, perfect. All right. So I guess the time is 9. So we finished like in an hour, which is good. So tomorrow we'll be discussing about antiplatelets and thrombolytics, I guess, anticoagulants. So we'll be discussing those topics tomorrow. So we'll take it slow tomorrow, and yeah, so tomorrow just prepare for the antiplatelets, okay? And I'll see you guys tomorrow. And if you guys have any questions from any of the sections so far, I have educated. Like if you have any questions, you can ask me tomorrow. Okay, and yeah, enjoy the rest of the day. Okay, thank you.
Thank you, ma'am.
Thank you, ma'am.
Thank you.